All right, up next, we have Dr. Charlotte Destefano, who is a clinical psychologist with expertise in autism spectrum disorder, intellectual disability, and related neurological disorders. And she has been here for the last couple of days testing kids, part of our clinical research that's going on here. So welcome, Dr. Destefano.
Folks, nice to see everybody, those of you who I haven't already seen for assessments. As Vanessa said, I'm a clinical psychologist. I'm an assistant professor at UCLA. I have been working with the Duke 15Q Alliance for the last several years, coming to conferences, doing assessments, trying to understand more about the developmental and behavioral characteristics of kids with Duke 15. And I'm really excited at this conference to have gotten to know the other patient groups a little bit better who are here. As a clinical psychologist, I do a lot of evaluations with kids who have neurogenetic disorders, kids who have autism and intellectual disability. And I actually used to be a special education teacher. So I spend a lot of time talking to families about special ed planning, behavioral interventions, all of those sorts of, decisions that need to get made in planning and advocacy. So my talk today is really just sort of a whirlwind of all the sorts of things that I usually talk to families about in our clinic appointments. So hopefully for those of you who have heard me talk before, there's some new information, but I think this will probably be most interesting for families who haven't met with me or talked to me. And we're going to talk about all of, like I said, all the decision making that goes into these things, making sure you're familiar with the terminology. And then I also focus a lot on kids who are minimally verbal and nonverbal and helping to improve communication skills. So at the end, we'll chat a little bit about some of that stuff. All right, so we think about intervention and educational activities happening in a few different contexts. Once your child reaches school age, a lot of the things that they're going to do are going to happen in the school environment. And so that includes the classroom that they're in and the general curriculum and instruction that they're receiving, their related services. So those are things like speech and OT, and then any extracurricular activities that they participate in. The big things that happen at home tend to be in-home behavior therapy. We'll talk about ABA and different styles of ABA and what that is. And then the other thing that families use frequently at home is respite care, having a caregiver come to help you out at home. And sometimes other therapies might happen in the home, but we more often see those what we would call clinic-based, where you're going to a therapy center to receive speech therapy, occupational therapy, physical therapy, social skills groups, all those sorts of things. So when I'm first meeting with a family, I go through the history and try to understand what's the child receiving in school, what are they receiving at home, what are they receiving clinic-based, and get sort of a lay of the land of all those different components. So let's talk about school quickly. And there is another talk about IEPs this afternoon, so I'm not going to go through this too much, but I wanted to make sure that you guys have just sort of a basic understanding of some of the components that we want to think about. So a big piece of the school decision-making is going to be the classroom placement. And you might have heard the concept of least restrictive environment, that all kids have the right to be educated in the least restrictive environment that is an appropriate fit for their needs. And these are, these occur on a scale from being in a general education classroom with no extra help, or a general education classroom with some extra help, like having a one-to-one aid. And we typically refer to these as being an inclusion. So the child is included in the general education classroom. And then as you move further down, the child might spend some time in the general education classroom, but also go into a specialized environment, sometimes called a resource room, during the day for some extra help. And that's often called mainstreaming, so where they're kind of going back and forth. Sometimes the child might be in a self-contained special education classroom for most of the day, either totally in that classroom or occasionally going into the general ed classroom for portions of the day. And then down at the bottom of the triangle, we have what's considered the more restrictive environments. So kids who are in a fully special education school, where there aren't any typically developing peers even on the campus, kids who are in a residential placement, and then kids who are in a hospital or home setting, usually due to the complexity of their medical needs. And so these are the environments that people often refer to as being special education. If you say my child's in a special ed classroom, you usually mean that they're in one of these more restrictive settings, which is not necessarily a bad thing. It's just something that you as a family want to think about if you think that's the best setting for your child and if it's meeting their needs. So this is one of the big decisions that happens when you're starting school and doing the IEP and deciding where your child is going to go. Some other terminology that can be helpful to know is what sort of standardized assessment is in your child's IEP. So all kids in this country take standardized assessments. And for our kids who have IEPs, there are different options for what those assessments are going to look like. They might be taking the regular standardized assessments with accommodations, with things like extended time, having frequent breaks, having someone to read the problems out loud to them. They might be taking the test with modifications, where there's actually some change to the content that's being tested, like being allowed to use a calculator for math problems that fundamentally changes the content. And for a lot of our kids with these syndromes, they're going to be doing what's called alternate assessment, where they have a whole separate set of assessments that are specifically created to be appropriate for the needs of kids with significant disabilities. So in California, for example, this is called California Alternate Performance Assessment, Kappa testing. Every state has their own version. And so that's something, it'll be a whole page of your IEP that talks about what the assessment plan for your child is and what type of assessment they're going to be receiving. All right, IEP goals are, of course, the meat of the IEP. These are going to be the major factor in determining what the services and placement are. And goals should be written for all of the areas of need identified by assessment and what are called the present levels of performance, which if you've already seen an IEP are those sort of narratives at the beginning where it describes what the child is able to do in each different area. I find it really frustrating when I see IEPs for kids with significant disabilities and they only have like 2 or 3 goals. Because I don't care how significant your disability is, you cannot convince me that the child is spending all day, every day for an entire year working on only 2 or 3 goals. So I really want to see an IEP that has a bunch of goals. They can be very incremental goals, but they should be across a variety of areas, because if you have a child who's not on the general education curriculum, they're not on grade level, their IEP dictates what their whole school day is going to be. There should be enough content in that IEP that you can imagine, okay, my child's going to work on these all day for an entire year. So no matter how behind your kiddo is in their development, you want to have a pretty good variety of IEP goals. Like I said, even if each goal is small and relatively easy to attain, I want to see some variety so that I know the kiddo has something to do all day. Related services are something parents seem to end up debating frequently with school districts. So related services are things like speech therapy, occupational therapy. Having a one-to-one aide is considered a related service in the IEP, adaptive physical education, physical therapy, anything other than the basic classroom setting is a related service. And parents and sometimes medical providers, I think, get frustrated when the school does not agree to the things that they think would benefit the child. And I think it can be helpful to understand the framework from which the school is working, and that'll help you advocate a little bit better. A related service, according to the federal special education law, I've listed out here their criteria for what means that, okay, you've met the burden of proof, and now we're going to give you this service that you're asking for. It's not enough to say that a child would benefit from a service. We have to demonstrate that if the child doesn't receive the service, then one of these criteria they're not going to meet. So we have to show that without the service, they're not going to be able to navigate the playground, or they're not going to be able to make progress in the curriculum, or they're not going to be able to benefit from some classroom instruction. So this seems to happen a lot with physical therapy. So our kids have a lot of motor complexities, and families and medical providers often expect the school district to continue providing physical therapy. Schools will usually discontinue physical therapy as long as the child can safely navigate the school environment, because their criteria is, they're accessing school, their physical challenges are not interfering with their ability to access school, and so we no longer have to provide that service. So it's a little bit of a different framework, and if you're trying to advocate for additional speech therapy hours or some other type of service in school, it's helpful to remember it doesn't matter whether or not your child will benefit from it. You have to show how the lack of it is going to interfere with their ability to benefit from school. A little bit of a shift, but it'll help if you use that language in an IEP. All right, so like I said, there's another talk this afternoon on IEPs, so we'll move on to some other areas. So clinic and home-based services are generally either funded through your regular health insurance. Sometimes they can be state funded through your state's Department of Health and Human Services. So in California, this is called Regional Center. There's a different version of it in every state. Or it can be self-pay. Some families end up just paying out of pocket for services that they're having a hard time getting covered. So we're going to talk about behavioral therapy, because this is the main component of the home intervention program. And I think there are sometimes a lot of misconceptions about what all these words mean. So we can think of behavioral therapy as being on a continuum from a more structured adult-led style to a more child-led interactional style. And we'll talk about what some of these are. So discrete trial training and verbal behavior are versions of ABA that are very structured and adult-led. Pivotal response therapy is going more towards the child-led side. Then we have Early Start Denver model and Jasper. I'll talk about what exactly these are that are kind of in the middle. And then you may have heard of floor time or DIR, which we can think of as being all the way on the child-led side. And these are all different types of behavior therapy. And there are lots more and more acronyms. I just picked some of the most common ones that you're likely to hear. So what are all of these things? Most of them fall under the umbrella of ABA. And I think the next talk is Dr. Call, who's going to talk about interventions for severe challenging behaviors, which is also under the umbrella of ABA. We are going to be talking more about the style of therapy that you're doing at home for the purpose of learning and shaping behavior, but not necessarily dealing with the sort of challenging behaviors he's going to talk about. So ABA is an umbrella term for most types of behavioral treatment used in autism and kids with overlapping neurogenetic disorders. And the overall goal is to shape and reinforce new behaviors and reduce undesirable ones. It's focused on improving all domains of functioning. If you're doing an ABA program, you're going to have goals just like you would in your IEP that outline what you guys are working on and what the child is working towards. Floor time, or DIR, is not under the umbrella of ABA. This is a style of intervention that builds relationships and abilities by following natural emotions and interests of the child, is how it's described. Floor time is something that I think can feel really positive to parents because there's not a lot of pushing the child. There's a much more of following what the child is naturally interested in, joining in with them. The thing to look out for is whether or not floor time is really getting the child to develop any new skills, or if it's really more just sort of a structured, fun playtime, which is also great. But there's not as much research evidence that floor time really gets kids to try new things and gain new skills. Because it is child-led, the adult isn't introducing new ideas or pushing them to do different things. Sometimes it's a little bit more stagnant in that way, where a more truly behavioral approach is going to include a little bit more structure and pushing the child along. All right, so discrete trial training, as I mentioned, is sort of the old school ABA. If you have a negative stereotype in your head about ABA, you're probably thinking of discrete trial training, where the child's sitting at the table, the adult is directing the activity, and they're practicing a specific skill over and over and over again, and then the child gets some sort of reward or reinforcer for successfully demonstrating that skill. Pivotal response therapy was probably the first more naturalistic version of ABA that became popular. This was developed by the Kegels at UCSB. And this is more play-based that incorporates the child's interests and the child's initiations. But the adult is still structuring the activities, structuring the interaction, targeting various what they consider pivotal areas of development, and using a combination of naturalistic and directive strategies. And then just as another example, Jasper, also developed at UCLA by Dr. Connie Kazari, who I did my PhD with, so spent lots of time doing Jasper intervention, is another version of play-based intervention that is child-initiated. This one targets pre-linguistic skills like joint engagement, joint attention, symbolic play, and uses naturalistic strategies and modeling to encourage the child to use new skills and new behaviors. And so one of the important differences here is that in discrete trial training, which is this more structured version of ABA, you're breaking things down into each specific skill that you want to teach and practicing them one at a time. So if you're working on recognizing colors, you're going to work on identifying blue, and then you're going to work on identifying red, and then you're going to work on identifying green. And that is really good for establishing brand new skills, where the child really needs to have it made explicit, and they need to practice just that one specific thing until they've got it. But as you can imagine, the whole range of skills and abilities that we want our kids to have, if we teach them all one at a time, they're going to be 80 years old before we get through all those skills. It's going to take a very long time. And so we think of more naturalistic versions like PRT and Jasper and Early Start Denver model as being more helpful for skills that are going to generalize from one area to another and one concept to another. So there's a time and a place for both of these types of models for sure. It's not to say that one model is better than another. And so you want to think about, when you're working on your child's intervention plan, what's a good fit for where my child is and what I want them to be learning right now. Some kids have a discrete trial portion of their ABA program where they're just working on drilling and establishing brand new skills. And then they spend time doing more play-based, child-led interaction where they're working on generalizing some of these more fundamental skills. All right, progress measuring might have gotten talked about in the neuropsychology talk already this morning, but I'll just mention a couple points quickly. We want to track progress in our kids using objective measures. It's really helpful to have some numbers to inform our understanding of what's happening. And if there's no progress towards goals after several months, then something needs to change. Either the goals are too hard, and so the child isn't able to sort of grab on and make that first step and start, or they're too easy and the child just doesn't particularly care anymore. Maybe they're really, really good at identifying their colors and they're sick of someone asking them to do it and they're just not going to do it anymore, and it's because it's too easy and they're bored. Sometimes the teaching strategy is wrong. Sometimes we're using a more directive style when a more naturalistic style would be better, or the opposite. Sometimes we're trying to teach something in a naturalistic interaction and the child actually needs a more structured, discrete opportunity to break those skills down and practice them. Sometimes we can decide that the goal just isn't a priority. And this is where families hopefully have a lot of influence. If your IEP team and intervention team is not interested in your priorities, then something's wrong and you need to switch that team up. You know, sometimes the therapist might have written a goal for the child to identify their colors and the family is like, I really could not care less if she ever learns to point to blue and point to green, you know, but I would really love her to be able to tell me what she wants to eat for lunch and point to pictures to show me what she wants for lunch. And so sometimes just changing up the goals to fit what your family priorities are can be really helpful. And then you want to have some sort of a comprehensive evaluation, probably every 2 to 3 years, to just figure out where your child is in general across all of the developmental domains. Are some domains progressing faster than others? Are there areas of weakness where we could do some additional intervention? Are there areas of strength that we could build on? If your child is school age and in the special education system, they'll be getting a school district evaluation every 3 years, which often has all of the information that you need in it. But you can also go to a psychologist or a developmental pediatrician or someone else to do a comprehensive evaluation if you want. You can come see me in LA. So a lot of our kids are going to perform at the floor on standardized assessments. And what this means is that for all standardized assessments, there are a range of scores, and those scores are what's called normed, meaning that we know we can look up in a table that for 6-year-olds, the average 6-year-old gets a score of, let's say, 30 on this assessment. And then as those scores go up or down, we know that they are doing better than the average kid their age or behind the average kid their age. And because assessments are normed on typically developing children, the norms don't tend to go down far enough to really capture where our kids are at. And so this leads to standard scores either staying flat or sometimes even going down all the time, even though the child is gaining skills. So you don't have to understand the psychometrics of why this happens, but just be aware of that fact when you get your assessment report. When you see the standard scores, it may look like your child is not changing over time, and it may look like they're getting worse over time, but that is not what's actually happening. And I'm going to show you an example of this. So this is a kiddo with Duke 15Q who I saw a couple of times, and this is their scores from the Mullen scales of early learning, which is the assessment that we're doing here at the conference. And you can see that I evaluated this kiddo about 2 years apart, and their standard scores and their percentiles have not changed at all. It looks like they have the exact same performance on both assessments. And so if you looked quickly at this, you might think, well, that's a bummer. My kid hasn't learned anything in 2 years. But if we look at the age equivalent scores, or you could look at the raw scores, but I have age equivalents here, you can see that this child has actually gained developmental abilities in every domain. So for example, their gross motor skills were at about a developmental level of 22 months, and now they're at about 25 months. Their visual reception, which is like patterns and matching and things like that, was 17 months when they were first assessed, and now it's at about 21 months. Their receptive language went from 9 months to 15 months. For our kiddos, these are really great gains, and they're not at all captured in the standard scores. So, you know, this is something that the professionals who are evaluating your kids should be aware of and should be interpreting appropriately. But I think it's just nice for parents to be aware of how these scores work and how they look, and what to expect when you're seeing evaluations over time. All right. Let's see, Vanessa, is Vanessa in here? I was gonna pause and do questions, but I don't know how that works with the live stream. I was gonna say, does anyone have questions before I switch gears and start talking about communication interventions for kids who are minimally verbal or nonverbal? Yes. Yes. Okay. Awesome.
She's 9 now. Oh, thank you. Okay, so we're transitioning to a school. She's 9. She's been in ABA all this time. All of this stuff's very familiar. My question to you is if you have any guidance on how to talk to schools about allowing ABA therapists or to work better with your ABA center if you're going there part-time. Because my sense from the school is they want nothing to do with the ABA center. They separate it, and
yeah,
that's so frustrating.
It can be really difficult. So for those of you who are earlier on in your journey, by the time your kiddo is the age that Natalie is, they'll probably have different intervention programs, different therapists, things happening at school, things happening in the center, things happening at home. And as a parent, you feel like an air traffic controller, and you're trying to like get everyone to talk to each other and coordinate. And schools can be a really big sticking point. My guess, having formerly been a special ed teacher, is that a lot of it just has to do with liability. They don't want people in the school who are not their people. And I don't, you know, other than hiring a lawyer and sort of fighting your way in, I don't have a good answer for you other than to, you know, try to form personal relationships with the principal and the assistant principal and the people who are signing off on these things, preferably your child's teacher, who no one's going to tell you that the teacher has control over it. But if the teacher says, do not let that ABA therapist into my classroom, the principal is probably going to support the teacher's perspective on that. So if you can get the teacher on your side, that can help. And all of the sort of informal campaigning and advocacy that you can do, short of bringing in an actual advocate or an attorney, is probably the best idea. And then on the flip side of that, talking to the ABA agency and making sure that they are willing to be in the classroom environment, but have the therapist following along with what the teacher asks them to do. Because I'll tell you, as a former special ed teacher, the last thing I wanted in my classroom was a rogue therapist who wasn't gonna follow my behavior plan or, you know, follow my classroom structure or something like that. So making sure that everyone's sort of on the same page about what the relationship's gonna be and who's gonna be making decisions from a minute to minute basis will hopefully help everyone feel a little more comfortable and be more flexible about that. What are we doing schedule wise? Because we got started pretty late. So what do you want me to do? Yes, but I can, whatever you guys want. Yeah, because I know Nathan's probably waiting to do his talk, right? Got it. Okay, guys, so since we're running a little bit behind and I'm here in person and Dr. Call is on the East Coast eagerly awaiting his talk slot, and since I'm at sort of a stopping point here, we're gonna stop so that Dr. Call can do his talk, and then we'll find another time where I'll finish talking about communication interventions for kids who are nonverbal or minimally verbal. So stay tuned for that. Sure, no problem.
Thank you, Charlotte.